Welcome back, guys. The topic that we shall be studying is Hodgkin's lymphoma. The etiology responsible for Hodgkin's lymphoma is Epstein-Barr virus, and the second virus that you should remember is HIV virus. The classical histopathological finding that is encountered in these patients is Reed-Sternberg cell, and the appearance of the Reed-Sternberg cell can be given in an image-based question, which is very simple, straightforward, and an easy one to identify. You will be able to identify the classical Aulai appearance. So when you read a question that mentions the fact that the excision lymph node biopsy in a patient is showing this particular representation of a owl eye appearance due to the prominent nucleoli present in the cell, then we are going to call this cell as a Reed-Sternberg cell. Reed-Sternberg cell is CD15 and CD30 positive. It is also CD45 positive, but CD45 is a leukocyte common antigen. It is present on all white blood cells, so the main feature flow cytometric marker for this is 15 and 30. Now let us understand why patients of Hodgkin's lymphoma will present to us. This disease has a bimodal age of distribution. What I mean by bimodal age of distribution is that either it will be seen in young patients or in old age patients. So usually we get a spike around 15 to 35 years of age, and then in relatively older patients. Most patients would come to us because they will be having a progressive increase in the size of cervical lymph nodes. Progressive cervical lymphadenopathy is a presentation in these patients, and it could result in misdiagnosis with tuberculosis, because as you are all aware, in India in tuberculosis, cervical lymphadenitis can definitely be common. Extrapulmonary tuberculosis, cervical lymphadenopathy is one of the presentations of extrapulmonary TB in our country. Now in tuberculosis, the consistency of the lymph nodes is matted, M-A-T-T-E-D, matted, but rubbery consistency of the lymph nodes will point towards etiology as Hodgkin's lymphoma. The lymph nodes will become bigger and bigger in size, and these lymph nodes, when they become bigger, they follow a anatomical setup in a sense that they have a contiguous spread. What I mean by contiguous spread is, like, let me say horizontally, these are the vertical group of lymph nodes along our internal jugular vein, cervical group of lymph nodes vertical around the internal jugular vein, and these are submental lymph nodes that is on the horizontal change. Now suppose there is a cancer that is Hodgkin's lymphoma developing in the horizontal chain. The lymph node will become bigger and bigger, and then it will involve the next one by direct contact, as well as it will also exhibit a lymphatic spread. Since Hodgkin's lymphoma will spread via lymphatics, it will have a relatively good prognosis, and gradually I will find that all these group of lymph nodes, horizontal ones, will get involved. Then it will involve the vertical group of lymph nodes serially. So because this follows a contiguous spread, unlike non-Hodgkin's lymphoma that can spread via both lymphatics as well as bloodstream, the quality of life in non-Hodgkin's lymphoma will obviously be bad, and prognosis will also be bad, and therefore Hodgkin's lymphoma patients will have a better life expectancy. Following a cervical lymphadenopathy, there is a possibility that in these patients the hilar lymph nodes can also become enlarged. The downside of this is hilar lymphadenopathy can press on the superior vena cava, and it can cause a manifestation of superior vena cava syndrome. How will superior vena cava syndrome present? It will present with facial congestion. The venous return of the face and the head and neck would be affected, so extensive facial congestion or facial plethora will be noticed. The lymph nodes can then press on the trachea. This can result in development of stridor in the patient. The lymph nodes can press on the thoracic duct. Thoracic duct is responsible for transportation of chyle. So these patients can be having a development of chylosositis. These are manifestations that would be encountered in case hilar lymph nodes are involved, and it is serially that, like, first if it is cervical, then hilar, then gradually it will go down into the abdomen, and abdominal group of lymph nodes will also be enlarged. In Hodgkin's lymphoma, if the abdominal group of lymph nodes will be involved, the lymph nodes at porta hepatis area will exhibit an enlargement. This is going to cause compression of the common bile duct. The compression of the common bile duct will result in obstructive jaundice, that is cholestasis. This cholestasis will explain the development of pruritus that is present in these patients, and obviously subsequently jaundice or icterus can also develop. The increase in the size of the lymph nodes can even press on the portal vein. Compression of the portal vein will result in development of portal venous hypertension or portal hypertension, and portal hypertension can then result in development of esophageal varices. So porta hepatis lymphadenopathy that develops in these patients will take some time to manifest, but the problem is that if it develops, it will definitely have a bad prognosis. Even the retroperitoneal group of lymph nodes can be enlarged in these patients. Now, retroperitoneal organs like ureter can be affected due to retroperitoneal lymphadenopathy due to kinking of the ureter of the patient. Due to pressure on the ureter of the patient, there can be a development of hydronephrosis. The impairment to the flow of urine will cause back pressure changes and kidney can be damaged. So you can see that it's not only about cervical lymphadenopathy or rubbery consistency of lymph nodes, but multiple group of lymph nodes can be involved serially over a period of time. These patients can also be having significant weight loss, which is defined as more than 10% decrease in the weight of the patient over a span of something like 6 months. Due to decrease in the weight of these patients over the span of 6 months, the weight of these patients will definitely reduce. Then also these patients will be having excessive sweating. So the MCQ might use the word drenching night sweats in a patient. These symptoms can be mimicking the symptoms of tuberculosis. There would be a tremendous decrease in the appetite of an individual, and these symptoms can again cause misdiagnosis with possibility of tuberculosis in practice as well as in MCQ. If these features are present in a patient, we tend to call this as category B symptoms. We will call the patient as category A if you do not have these symptoms which mimic symptoms of TB. But if you have these symptoms present, then we label the patient as a category B patient. These patients will also be having fever since there is a lymphoreticular malignancy. The cytokines which are present in this condition can result in development of resetting of the temperature related to the hypothalamus, because hypothalamus is the thermostat in the body, and Pale-Epstein fever can develop. Now, what is Pale-Epstein fever? This will be clear from this diagrammatic representation. As you can see in the figure, in Pale-Epstein fever, what will happen is that the fever will be there for few days and then the fever will disappear. So, as you can see in the figure, the fever lasting for few days. This is like he has fever for few days, then he's afebrile, then again fever is there. So, this presentation of Pale-Epstein fever is very classical to Hodgkin's lymphoma. When you evaluate these patients, the values of LDH in these patients is elevated. LDH can be taken as a indirect marker for malignancy, also for inflammation, but a marker for malignancy. So LDH values would be elevated in these patients. We have to do a CT of the abdomen and of the chest of the patient. And nowadays the textbook mentions that whole body PET scan is recommended to demonstrate which group of lymph nodes are involved and not involved in the patient, because when you will treat the patient, you will notice that the involvement of the lymph nodes will become progressively lesser. If you can just look at this image, like images like these can be given. These images are those of a PET CT. That is, two techniques are being combined, a PET CT. And you can see in the patient that initially the tracer is become concentrated at multiple areas of lymph nodes. Multiple group of lymph nodes are involved. And then subsequently you can see there is an improvement in the condition of the patient. So whole body PET scan will be recommended for diagnosis of these patients. Along with this, obviously CT chest can be combined to actually see the real mass effect on which tissues are getting involved in the patient. CT abdomen will simultaneously be done in these patients, and then the investigation of choice for these patients will be excision lymph node biopsy. On this excision lymph node biopsy specimen, I can also be doing a test by the name of flow cytometry. And when I perform the flow cytometry report on the patient, then the flow cytometry report of the patient will say CD15 and CD30 positive, which is again a good pointer to the diagnosis of this particular condition. For the staging of this patient, we tend to use what is known as Ann Arbor classification. Ann Arbor classification is mostly based on clinical staging. What I mean by clinical staging is, that I will call the patient as stage 1 if only one group of lymph node is involved or one lymphatic area is involved. So one group of lymph nodes or one lymphatic area is involved in the patient, like cervical area is the only one that is involved. But if in a patient there is a involvement of two group of lymph nodes on the same sides of the diaphragm, like two groups of lymph nodes, like for example axillary lymph nodes as well as hilar lymph nodes on one side on the same side of the diaphragm are involved, then I will say that the patient is having a stage 2 Hodgkin's lymphoma. For stage 3, there would be two group of lymph nodes that would be involving both sides of the diaphragm, as well as it could be above and below the diaphragm also. And if there is a dissemination and multiple group of lymph nodes are involved, then we will say the patient is having stage 4 Ann Arbor classification. So this classification is just on clinical grounds. In pathology, they teach you about WHO modified real classification. WHO modified real classification that is based on the histopathological subtypes of various varieties of Hodgkin's lymphoma that you will come across. So WHO modified real classification is not a clinical classification. The subtypes that you would have studied in pathology and I'm making you revise are nodular sclerosis, another one that is encountered is mixed cellularity, then is lymphocyte rich variety, then is lymphocyte depleted variety, and the last variety that is obtained is called as nodular lymphocyte predominant variety. Now these are names that you read in pathology also, so it should be pretty straightforward. I'm putting a line in between to say that the superior ones are called as the typical and the last one is called as atypical. Why nodular lymphocytic predominant is called atypical is because one, it is extremely slow growing. It is so slow growing that it might have been diagnosed in a person at 25 years of age, and when this person is 60, it is almost of the same size. It is of the same size. So there is no need for surgical removal of lymph nodes in nodular lymphocytic predominant because of extremely slow growth. I repeat again, the growth can be so slow that when you saw the same patient after 40 years, the tumor was almost of the same size. And then this tumor is also CD15 and CD30 negative, whereas Hodgkin's lymphoma or Reed-Sternberg cell is classically CD15-30 positive. So because of the fact that this is very slow growing and it is CD15 and 30 negative, it is called as the atypical variety of Hodgkin's lymphoma. Histopathologically speaking, the cells which are present here are referred as popcorn cells. That's just a name to be remembered. Popcorn cells are a feature that are encountered in nodular lymphocytic predominant variety of Hodgkin's lymphoma, which is the atypical variety. This is the commonest variety, guys, the most common one. Nodular sclerosis, that is the most common one on a global basis. This will be having particular cells which are referred to as lacunar cells, whereas the one that is commonest in India is the mixed cellularity variety. This is the one that is having classical Reed-Sternberg cells. I repeat my data again, classical Reed-Sternberg cells are encountered in the Indian variety. Mixed cellularity is also to be remembered because of association with HIV. If they ask you that which variety of Hodgkin's lymphoma is found in HIV positive patients, the answer will be mixed cellularity variety. Lymphocyte depleted variety tends to be having the worst prognosis. And when it says best prognosis, then do not fall in the trap and answer lymphocyte rich variety. It is lymphocyte predominant variety that has the best prognosis because it is very slow growing. So there is no need for surgery even in it. This is a WHO modified real classification with special emphasis on these classical names like lacunar cell, popcorn cell. Related MCQs that I can relate here are: one, remember the fact that if you read about popcorn lesion on a chest X-ray, Then popcorn lesion on chest X-ray is a feature that is encountered in patients who are having a benign tumor of the lung, and the benign tumor of the lung is called as pulmonary hamartoma. Whereas when you read about a popcorn lesion on a mammography, then this is a lesion that is in favor, popcorn lesion on mammography, then this is a lesion that is suggestive of diagnosis of a benign tumor of the breast, that is fibroadenoma. So 3 questions on popcorn I've just mentioned here before you: fibroadenoma, a pulmonary hamartoma, that is the benign tumor in the lung, and then popcorn cells for lymphocyte predominant variety. For HIV positive patients, guys, remember that the brain tumor that is found in HIV positive patients is diffuse large B-cell lymphoma, is primary CNS lymphoma. But if they say which Hodgkin's lymphoma is common, I'll repeat the data again. AIDS patients could be having a brain tumor that is called as primary CNS lymphoma. AIDS positive or HIV positive patients can also be having a non-Hodgkin's lymphoma. The non-Hodgkin's lymphoma in AIDS positive patients is immunoblastic subtype. This is a subtype of diffuse large B-cell lymphoma, immunoblastic subtype. And the commonest variety of Hodgkin's lymphoma in AIDS positive patient is the Indian variety, that is the mixed cellularity variety. So I repeat the data once again. For AIDS positive patients, the brain tumor that is seen in is primary CNS lymphoma. The non-Hodgkin's lymphoma is the immunoblastic variety, and Hodgkin's lymphoma is a mixed cellularity variety. This is purely a histopathological classification. Ann Arbor is a clinical classification for seeing how many group of lymph nodes are involved in the patient. Remember the fact that for the workup of these patients, CT and a PET scan is mandatory, and words like Waldert ring would help you in narrowing down the diagnosis of this particular disease. For treatment of patients of Hodgkin's lymphoma, for localized disease like only cervical lymphadenopathy is present in a patient, then the treatment that will be given to the patient will be mainly radiotherapy. It would be radiotherapy to the local area, or it could be radiotherapy only to the lymph node. But if we talks about advanced disease where multiple group of lymph nodes are involved in a patient, then the chemotherapy that should be started in the patient is by the name of ABVD. Though Stanford regimen is also used, which incorporates more drugs, that means more toxicities also. It is ABVD that is usually to be answered as the chemotherapy of choice at the moment. So A would stand for adriamycin, B would stand for bleomycin. You can think about the V, which is vinblastine, and D, you guys can tell me. The D would stand for, the D stands for not doxorubicin, because doxorubicin and adriamycin is same. It's not daunorubicin either. This is dacarbazine. So adriamycin, bleomycin, vinblastine and dacarbazine is the ABVD protocol, which is useful for management of patients who are suffering from Hodgkin's lymphoma. The topic that we shall be discussing this time is NHL, that is non-Hodgkin's lymphoma. Now, when I compare the incidence of non-Hodgkin's lymphoma, the incidence of non-Hodgkin's lymphoma is much more common as compared to Hodgkin's. I mean, overall, 85% is non-Hodgkin's lymphoma for lymphoreticular malignancies, and 15% is Hodgkin's lymphoma. When it comes to non-Hodgkin's lymphoma, we should know the etiology. Why do we have development of non-Hodgkin's? Then the common viruses which are responsible are Epstein-Barr virus and HIV virus. We all know that. But apart from this, I also want you to remember that even HTLV1 is incriminated in causing development of non-Hodgkin's lymphoma. Then Kaposi sarcoma herpes virus, KSHV, which is responsible for Kaposi sarcoma in AIDS positive patient, is also a non-Hodgkin's lymphoma. Then hepatitis C virus causes lymphoplasmacytic lymphoma, as I'll mention subsequently, but this is list of viruses which are responsible. Then even chromosomal translocations are responsible for causing development of Hodgkin's lymphoma. And if they ask you in the exam that which is the most common chromosomal translocation that is responsible for non-Hodgkin's lymphoma, it is T14:18 translocation. T11:14 translocation is responsible for causing a non-Hodgkin's lymphoma by the name of mantle cell lymphoma. Whereas if the question is simply asked as what is the most common chromosomal translocation which is incriminated in causing development of non-Hodgkin's lymphoma, then the answer should be given as T14:18 translocation. This is the commonest translocation that is seen in NHL, especially in the follicular lymphomas. This is very commonly seen. So viruses and chromosomal translocations are responsible for manifestations. Now we look at clinical features in non-Hodgkin's lymphoma. Non-Hodgkin's lymphoma will occur in patients who are again elderly. The median age of presentation is about 67 years of age, and these patients will be presenting with simultaneous involvement of multiple group of lymph nodes. Because non-Hodgkin's lymphoma will be having presence of hematogenous spread, so multiple group of lymph nodes enlarged simultaneously can be present. Most of the time the presentation will be a painless adenopathy like cervical adenopathy, axillary lymphadenopathy, hilar lymphadenopathy, retroparietal lymphadenopathy. All could be present simultaneously in a patient. That is usually the profile of the patient, but it would be multiple group of lymph nodes. Do remember the fact that Burkitt's lymphoma is common in pediatric age group, but otherwise most of the non-Hodgkin's lymphoma are present in adult age group. Burkitt's in adult can present with abdominal lymphadenopathy. I'll just mention it here. Burkitt's lymphoma can present as jaw swelling, especially in an African child. You would have seen this picture multiple times in the book. I'll just bring it to your focus, which can cause airway obstruction and can cause difficulty with eating of food also. So especially with the African child, jaw swelling. And Burkitt's lymphoma in an adult can present with abdominal lymphadenopathy, which is so big that it can cause development of even intestinal obstruction. If retroperitoneal lymph nodes would be involved, it can also cause development of hydronephrosis. So genitourinary complaints in the form of hydronephrosis and intestinal obstruction can be presentation of Burkitt's lymphoma in adult population. In children, it would be a jaw swelling and can cause impairment of the airways of the patient as well. Then in these patients, you could be having presence of category B symptoms. Category B symptoms are defined as presence of weight loss, which is more than 10% of the total body weight. Over the previous 6 months. Then can be drenching night sweats in a patient. And this could be associated with fever. It could be evening rise of temperature, where temperature usually recorded by digital thermometer going beyond 38 degrees Celsius. So category B symptoms can be present in both Hodgkin's lymphoma and non-Hodgkin's lymphoma. Because of the hematogenous spread of the disease, it can cause bone marrow involvement. Now, if the cancer cells will spread to the bone marrow of the patient, the bone marrow involvement of the patient can cause pancytopenias. So therefore, this non-Hodgkin's lymphoma patient will be having anemia. He could be having recurrent infections, and thrombocytopenia can manifest in the form of petechiae. So cytopenias are the manifestation that can be seen in non-Hodgkin's lymphoma but not in Hodgkin's lymphoma. This disease can also spread to central nervous system. So it can contribute to spinal cord compression, which could contribute to paraplegia or quadriplegia in a patient. It can even cause cranial nerve palsies in a patient. When it comes to Hodgkin's lymphoma can also be having a CNS manifestation, but this is a paraneoplastic manifestation that is seen with Hodgkin's lymphoma. That is, the paraneoplastic manifestation with Hodgkin's can be Guillain-Barré syndrome. The autoantibodies which are produced can cause damage to the spinal cord. So Hodgkin's lymphoma can cause a paraneoplastic manifestation, Guillain-Barré syndrome, but here it is a direct physical mass effect on the tumor. It could be vertebral metastasis, or it could be spinal cord compression or cranial nerve palsies in a patient. So lumbar puncture is done in patients of non-Hodgkin's lymphoma to see for the CNS involvement of the patient, unlike Hodgkin's where it's a paraneoplastic manifestation. Now, once these patients come to you, you'll have to do a workup And the workup of these patients will involve the following tests to be done. Due to cytopenias, the hemoglobin will be lesser, the TLC will also be lesser, the platelet count of the patient will also be lesser. You will be checking LDH values in the patient, which are always increased in malignancy and inflammation. Beta 2 microglobulin levels can be checked in the patient. Beta 2 microglobulin levels in the urine signify a bad prognosis in these patients. The word is beta 2 microglobulin, not beta 2 transferrin that is present in CSF. You do beta 2 transferrin levels to evaluate for CSF in CSF otorrhea or CSF rhinorrhea. But this is beta 2 microglobulin levels that I will be evaluating. Then I'll be doing a MRI of the abdomen and I'll be doing a MRI of the chest of the patient because I want to do Ann Arbor staging in this particular case also. A PET scan will also be done in this case. In fact, it's a must to do a PET scan nowadays, a whole body PET scan or a PET CT in the patient to evaluate for the disease which is currently present and to then follow up the patient. And this can differentiate whether lymph node is there or there is a necrosis which is present in the lymph node. So the changes in the lymph nodes can also be evaluated by the reports of the PET scan. PET scan would be using 18-fluorodeoxyglucose. It is radioactive glucose which would be taken up by cancer cells and not by normal cells. In these patients, you might even have to do MRI of the spine of the patient because CNS involvement can be present in a patient, and lumbar puncture to see for the CSF involvement of this patient also needs to be done. Once you have done a workup of this patient, you will then come to the investigation of choice, which is the excision lymph node biopsy with a flow cytometry. Now, when you do a excision lymph node biopsy in a patient, you will be able to evaluate whether it is a B cell variety or a T cell variety and which variety of lymphoma is present. Even FISH can be done in these patients to identify the chromosomal translocations like 14:18 is one of the common ones, as I've told you. Or for Burkitt's lymphoma, the chromosomal translocations which are associated are 8:14, 2:8 and 8:22. These are chromosomal translocations which are related to Burkitt's lymphoma. So FISH can be done for these patients. And then excision lymph node biopsy is the investigational choice. Here I'll just mention regarding the WHO modified real classification for non-Hodgkin's lymphoma. In WHO modified real classification, remember that non-Hodgkin's lymphoma can be B cell variety or it can be a T cell variety. Almost 80% of these are B cell variety and the remaining can be T cell variety. If they ask you that what is overall the most common variety of non-Hodgkin's lymphoma, like I discussed in Hodgkin's lymphoma, it was nodular sclerosis. Here I'm saying DLBCL, that is diffuse large B cell lymphoma. However, if he mentions specifically that which is the most common non-Hodgkin's lymphoma that is encountered with HIV positive patients, then it should be answered as immunoblastic lymphoma. I've said this earlier also and repeating once again, Hodgkin's lymphoma common with HIV is mixed cellularity variety and the non-Hodgkin's lymphoma that is common is immunoblastic lymphoma. Then with hepatitis C, the variety that is seen is known as lymphoplasmacytic lymphoma. You just need to get the names right, lymphoplasmacytic lymphoma. Then there's a bacteria in the stomach by the name of Helicobacter pylori that can cause a maltoma, mucosal associated lymphoid tumor, and maltoma is present in the stomach. This is caused by bacteria. Normally we have virus associations. I'm talking about maltoma. Then we have KSHV, that is Kaposi sarcoma herpes virus. This is responsible for causing Kaposi sarcoma. In AIDS positive patient, it is a vascular tumor. It will bleed on touch. Oral cavity and peripheral extremities are the ones that are involved. Even systemic involvement can be seen in Kaposi sarcoma. The vascular tumor can even bleed on touch, or internal bleeding can be a manifestation. Treatment is obviously combination antiretroviral therapy. So these are a couple of associations with non-Hodgkin's lymphoma that you need to remember. And yes, then another association to be remembered is with chromosomal swaps, that is 8:14, 2:8 and 8:22. These are related to Burkitt's lymphoma. Now remember the fact that when it comes to Burkitt's lymphoma in a patient, Burkitt's lymphoma on histopathology can present with a starry sky appearance. This is why the starry sky appearance will appear. If you look at this slide, you can see some fat inclusions which are present inside these Burkitt lymphoma cells, these fat inclusions that give a starry sky appearance. This is a magnified view. A less magnified view can also be given to you in the paper with a slide, which would look something like this. Now, what I want you to pick up is that in Burkitt's lymphoma, there is fat inclusions present inside the Burkitt lymphoma cells, and once they're phagocytized by the macrophages, then the cells will look totally clear from inside. Like you can see, there is like sheets and sheets of cells, right? And then between you can see some clearing inside the cells. This clearing inside the cells is that gives a star. Like I'll say a star is born when there is clearing inside a Burkitt lymphoma cell. So this is a relatively more magnified view. You can see starry sky appearance, classical, right? And then the clearing inside the cell will give a starry sky appearance in the patient. Starry sky in a CT head is a feature that is seen with neurocysticercosis, but starry sky appearance on a lymph node biopsy is a feature of Burkitt's lymphoma. These are the chromosomal swaps that can be seen. This could be related to CMYC. This results in generation of CMYC, which inhibits apoptosis, and you can understand the fact that the inhibition of apoptosis is the one that is responsible for the cells not dying. So these are associations for the B cell variety. Now we come to T cell variety of non-Hodgkin's lymphoma. The special feature of T cell lymphoma non-Hodgkin's variety, which is to be remembered, is called as cutaneous T cell lymphoma, or is called as mycosis fungoides. Why it is asked is because of very peculiar manifestation, that there would be extensive redness involving the entire skin of the patient, that is called as erythroderma. They can give you an image-based question like this, where they can mention regarding these red patches present all over the skin of the patient, that on first look might look like some infection, but then these extensive redness over the skin of the patient is referred to as erythroderma. In the same patient, they can be giving you peripheral smear finding where you might be able to see what are known as Sézary cells. Now I'll bring those Sézary cells into focus. These would be T cells which are having a cleft appearance. If I just bring that focus here, you can see the cleft appearance of the nucleus of the cell, the cleft appearance of the nucleus of the cell. This is Sézary cells that are seen in this patient with erythroderma. So the presentation is also known as cutaneous Sézary syndrome, and subsequently in these patients the dissemination can result in hepatosplenomegaly, or there could be a bone marrow involvement in the patient. There can be a bone marrow involvement that can signal development of cytopenias in a patient. Mycosis fungoides presents with skin involvement, that is erythroderma, the red patches, presence of Sézary cell, and hepatosplenomegaly, which is then gonna be called as cutaneous Sézary syndrome. The tumor will start from the skin and will disseminate to other organs in the body. The histopathological detail, another one to be remembered for mycosis fungoides would be that if you do a skin biopsy of this particular patient, you will be able to see a finding that is technically called as Portier's microabscess formation. Portier's microabscess formation is a histopathological finding that is encountered in these patients. Just pay attention to the words here. Just like you guys are comfortable with the fact that Monro's microabscess formation is seen with psoriasis. Similarly, I want you guys to remember the fact that Portier's microabscess formation is a feature that is seen with cutaneous Sézary syndrome, that is a T cell variety of non-Hodgkin's lymphoma. Others are like angiocentric lymphoma and other details which you can read from pathology, but this is like, I would say, a pathological details, a quick revision for you for the varieties of non-Hodgkin's lymphoma that you encounter. Now once you have identified these patients and you have found out the subtype, it is time for treatment. In non-Hodgkin's lymphoma, because patient is having dissemination most of the time, Ann Arbor classification, I can just highlight once again, most of the patients will either be stage 3 or will be stage 4 because multiple areas are involved simultaneously. We say Ann Arbor classification stage 1 if only one lymph node area is involved in the patient, like cervical area, or it is one extra lymphatic site. What I mean by extra lymphatic site can be like heart can be involved, skin can be involved. So extra lymphatic site, one area or one lymph node area involvement is stage 1. But if you are having at least 2 lymph node areas involvement in the patient, then in those circumstances these 2 lymph node areas should be on the same side of the diaphragm. Same side of the body, like left side axillary and left side hilar lymph node, same side of the diaphragm. On the other hand, if you are having 2 lymph node areas present, but they're present on both sides of the diaphragm, then we will say stage 3, and stage 4 would obviously mean dissemination in a patient where multiple organs like genitourinary or bone marrow involvement can be seen in the patient. Now, with help of this Ann Arbor classification, we'll be able to determine a international prognostic index or IPI in patients of non-Hodgkin's lymphoma. In international prognostic index, 1, you take into consideration age of the patient. Then you take into consideration Eastern Collaboration Oncology Group performance status. What I mean by performance status is this is just a evaluation of the quality of life, like whether a person can go to bathroom by himself, can he wear his own clothes. So performance status here means quality of life of an individual, like can he go out to his office, can he go to the bathroom unassisted, can he walk by himself. So ECOG performance status evaluates the quality of life index in a patient. Then we'll check about the values of elevated LDH in the patient. We take into consideration extranodal sites. If they're greater than 2 extranodal sites which are involved in the patient, that is definitely going to indicate a bad prognosis. It could be more than 2. And the third thing that we take into consideration in this prognostic index is Ann Arbor classification. And if Ann Arbor classification will be mostly stage 3 or 4, then it definitely indicates a bad prognosis. So the prognostic index in non-Hodgkin's lymphoma takes into consideration the following parameters, which are to be remembered MCQ wise. And if they say what is the treatment for this condition, the chemotherapy of choice for this condition is R-CHOP. In R-CHOP, we shall be using rituximab. Then we shall be using cyclophosphamide. That's an alkylating agent. Then H would stand for hydroxydonomycin. O would stand for oncovin, and P would stand for prednisolone for the patient. The word is R-CHOP, rituximab, cyclophosphamide, hydroxydonomycin, oncovin, and prednisolone is the treatment that we will do in the patient. And along with this, supportive care is anywhere required. If there is pancytopenia in a patient, blood transfusions would be required, or platelet transfusions can be required for the patient so as to ensure better survival of these patients. This is a classification for non-Hodgkin's lymphoma that I wanted to remember. The pathological part you can revise, in fact, before you start listening to this lecture once again. And do revise these parts of Hodgkin's and non-Hodgkin's, the lymphoreticular malignancies that I have mentioned before you. Why I'm emphasizing that is because in my discussion, if you've been listening from the beginning, you will notice the fact that I have described 3 conditions where he can begin with lymphadenopathy. CLL, Hodgkin's and non-Hodgkin's lymphoma. These are the various malignancies that you have listened to me today. I'm just putting artificial pointer to say that lymphadenopathy is a feature in all 3 of these. So what will tell you that it is CLL? It would be an old person with autoimmune hemolytic anemia or autoimmune thrombocytopenia that would be mentioned in the question. But for Hodgkin's lymphoma, he will mention regarding Pell-Epstein, fever present in a patient. And most of the time in Hodgkin's lymphoma, it will be cervical group of lymph nodes that would be enlarged in the patient. A rubbery consistency of lymph nodes can also be given in the question. For non-Hodgkin's lymphoma, it would be simultaneous involvement of multiple group of lymph nodes which are present. Along with this, because of bone marrow dissemination, cytopenias could be described in the question. Non-Hodgkin's lymphoma can be a child also, like an African child with a jaw swelling, and airway compromise could be given in the question as well. For chronic myeloid leukemia, the easy pickup point will be not a lymphadenopathy but a massive spleen. For the inferior two, there will always be development of fast onset anemia with bleeding, with sternal tenderness. I've already informed you the fact that if he talks about CNS involvement, then you need to think in terms of lymphoblastic leukemia. But if he talks about gingival involvement, or he uses a phrase like chloroma, chloroma would mean that there is involvement of tissues by myeloblasts, or he just says the fact that the patient is having leukemia cutis, then I will think in terms of acute myeloid leukemia in a patient. ALL will always be a child, or mostly will be a child. The investigational choice for these conditions is again a subject of I'd say discomfort for most doctors. The investigational choice for CLL is not excision lymph node biopsy, it is flow cytometry, where CD5 will be present along with B cell markers. Excision lymph node biopsy is only to be answered for patients who are having Hodgkin's and non-Hodgkin's lymphoma. For chronic myeloid leukemia in a patient, it is FISH fluorescent in situ hybridization to demonstrate the T9-22 reciprocal translocation, and bone marrow aspiration is the investigational choice for both acute lymphoblastic leukemia and acute myeloid leukemia. I'll now be mentioning the treatment algorithms for each one of them. This is purely from pharmacological perspective, though I have talked about stratification of patients into a good prognosis or low risk or high risk patient. For CLL, it was FCR or PCR, that is fludarabine, cyclophosphamide, and rituximab, with main drug being fludarabine, adriamycin, bleomycin, vinblastine, and dacarbazine. RCHOP, that is rituximab, cyclophosphamide, hydroxydonomycin, oncovin, and prednisolone with non-Hodgkin's lymphoma. Imatinib mesylate with chronic myeloid leukemia. Vincristine, adriamycin, L-asparaginase, and prednisolone with acute lymphoblastic leukemia. And ATRA, that is all trans retinoic acid, is a feature that is seen with acute myeloid leukemia in a patient. Thank you.